Welcome to the CIRCE project. Thank you for agreeing to be a part of this exciting research. As you know, CIRCE stands for Combining Intraplaque Neovascularization Risk Stratification with Carotid Stress Echocardiography. Ultrasound of the carotid arteries can be easily implemented during dobutamine and treadmill stress echoes to improve prediction of future cardiovascular events and the need for angiography.
Now remember your anatomy of the carotid. The right common carotid comes off the brachiocephalic, and the left common carotid comes off the aortic arch. Both of the common carotids come up, and then around the mid to high neck, they widen at the carotid bulb, and then bifurcate into the internal carotid and the external carotid. Remember, the internal carotid branches into the brain, and the external carotid gives off branches to the face and to the scalp. This area here, where the bulb is and the beginning of the bifurcation, that's where the turbulent flow occurs, and that's where plaque develops.
CIRCE involves the use of contrast agent to observe intraplaque neovascularization, a feature of vulnerable plaque. If contrast can be observed within plaque on echo, it means that micro blood vessels have infiltrated the plaque, making it more prone to rupture. Grade 0 plaque has zero evidence of neovascularization. A grade 1 plaque has evidence of neovascularization only in the shoulders, and grade 2 plaque would show contrast in the middle and throughout the plaque. What we need from sonographers is to find plaque in the carotid arteries if it is present, and then use contrast-enhanced ultrasound so that we can determine the risk factor of each lesion. You will be taking one set of images in B mode on both sides of the neck before any contrast is administered to the patient. This is typically easiest to do at the very beginning of the echo while patients are still lying horizontally on their backs prior to your baseline images of the heart for the stress test. But you can get these images at any time in the exam as long as there is no contrast in the blood vessels. In other words, the heart rate does not matter for any of the images needed for CIRCE and can be done whenever is convenient in the exam as long as some are retrieved before contrast. Another set of images will be taken with contrast in the system to observe if contrast infiltrates the plaque through those new blood vessels. You will want to use your machine's linear array transducer. On the Philips machine, this is the L12. On GE machines, use the 9L probe or whichever vascular probe your machine is equipped with. The indicator should always be pointed towards the patient's right in short axis and towards the head in long axis on both sides of the neck. Before we get into the images we need from you, let's go over machine settings. The gain level should ensure that the borders are clear and there's minimal noise in the lumen. Also be sure to adjust the focus and depth to focus exactly on the vessel. Since you'll be scanning both sides of the neck, all the images should be labeled right or left. It doesn't matter what order you do them in as long as they are labeled. The label should be present but out of the way of any areas of interest in the middle of the screen.
So to do a carotid assessment, you're going to have to assess both of the carotids. Here we're starting on the left. Have the patient lie supine and just have their head turned just slightly to the opposite side of the carotid artery you want to assess. You don't want to over-rotate them or the sternocleidomastoid will get quite taut and it'll push your probe away. Similarly, you may have to extend their neck a little bit to look at the carotid well, but overextension will really tighten those sternocleidomastoids and block you from getting a good view of the carotid. So a neutral position usually works well with respect to extension and flexion of the neck. And even though it's best to have the patient supine, you can usually get a pretty decent image even if they're at 45 degrees. So do the best you can. Alright, so once you have them positioned, we're going to start with a transverse view of the common carotid. So set your probe down on the neck with the indicator to the patient's right, just above the clavicle, and look for the common carotid. And this is what you'll likely see on the screen. In the near field, you're going to get a muscle, the sternocleidomastoid muscle, then a black hypoechoic internal jugular that's irregularly shaped. Over here, you'll get a hyperechoic rim with some scatter, that's the trachea, and in between is the round, thick, hyperechoic-walled common carotid artery. And then once you've centered the common carotid artery in the middle of your screen, you're going to slide the probe in a cephalad direction through the bulb to the bifurcation that'll look like this. There's the common carotid, it dilates out, that's the bulb, And there you see it divide into the internal carotid and the external carotid. The internal carotid usually being the bigger of the two.
While sweeping, remember to look for any plaque so that you can look for this later in longitudinal view.
This just shows that the ICA and ECA could be in any orientation, and identifying this is not important for CIRCE. Just try to get the bulb and the larger of the two vessels here at least, looking for any plaque.
Once you've achieved your transverse view, you're going to want to get a longitudinal view from the front of the neck. To do this, center the bulb in the middle of your screen, and then turn the probe so that the indicator is in a cephalad direction. This will give you a longitudinal view of the carotid, which will look like a pipe across your screen. And this is what you'll see on the longitudinal view. Note, screen left is going to be cephalad, screen right is caudad, near field is anterior, far field is posterior. This is the common carotid here, and we're going to slide in a cephalad direction. So there we go, sliding cephalad. You can see the bulb in the middle of the screen there, and then there's the bifurcation. So this is the ECA, this is the ICA, the bulb, and that's the common carotid. This is the bulb starting out here, and as we slide in a cephalad direction, coming out the other side, it'll be either the ECA or the ICA coming out here, and you won't know which one it is. Now I just want to draw your attention to the wall of the carotid. Note this hyperechoic white line just on the inside. That's the intima of the wall, that's normal. And then just more hypoechoic or black far field to it, that's the media or the muscular aspect of the wall. And then the bright hyperechoic external wall, that's the externa. So there's the hyperechoic externa, there's the hypoechoic media, and that white line, that hyperechoic intima.
Take a still image of the intima media here. We're using this to measure intima media thickness, another risk factor for cardiovascular disease. Next, take still images of any plaque that you observe. Make sure to hold the probe at an opposing angle to the plaque to get an optimal view of how large the plaque is. Plaque is most likely to accumulate in the bulb and internal carotid arteries, so please ensure that you capture all the angles that you can. Remember, more images are better than fewer, so if in doubt, take more stills than you think. If you do not see any plaque without contrast, take an image of the bulb and one of the internal carotid, or the tuning fork if you are able to do so. Then do the exact same process on the other side, ensuring that you relabel images when you switch over.
Recall that the probe stays pointed to the patient's right in transverse view and toward the head in longitudinal view on both sides of the neck.
Finally, we're going to get some baseline contrast mode images before any contrast is administered. The purpose of these is to get an idea of the noise present so that we can tell exactly what the contrast is illuminating. So, while the probe is centered on the bulb and ICA, where any plaque is present, turn on contrast mode and take a 5-second loop in longitudinal view. It should look something like this. It is important that you use the same settings for this baseline cineloop as you do when contrast is added later on. So, to summarize the non-contrast enhanced images, you'll get a short axis sweep of the common carotid up to the bifurcation. Then, you'll turn the probe longitudinally and get a still of the intima media on the common carotid. Then, you'll move cranially toward the bulb and internal carotid artery and get stills of any plaque present or stills of the clear arteries if there is none. Finally, you will get a 5-second loop of the bulb and ICA or any plaque in contrast mode, but without any contrast. Do both sides, then carry on with the stress echo. The second set of images can be done at any point in the exam, either at the beginning of the appointment while the heart rate is increasing, during recovery while waiting for the heart rate to reach resting state, or after all other images are collected at the very end of the appointment. These images require a dose of DEFINITY contrast to visualize plaque neovascularization. The solution of Definity needed for carotid scanning is 0.2 milliliters of Definity in 2.8 milliliters of saline in a 3 ml syringe to give you a 3 milliliter contrast solution. You will need 2 of these syringes, approximately 1 administered per side you scan. This is administered through an IV, just as you would use contrast for the echo portion. So here I am diluting 0.2 milliliters of Definity in 2.8 milliliters of saline in a 3 milliliter syringe, and repeating the exact same step for the other side. I will administer 1 full syringe to image one side of the neck's carotid arteries, followed by a flush of the line with 2 to 3 milliliters of saline, then usually will administer the second syringe when imaging the other side. If the participant already has contrast in their system, or the images look very bright and clear on the second side, you may only administer 1 or 1.5 syringes. In contrast mode, please ensure that you use Definity to brighten the images rather than adjusting the gain. If it seems dark, add more. During contrast administration, locate the bulb and internal carotid artery in long axis view, ensuring that any plaque is centered and clearly in view. While holding the probe longitudinally, use the contrast mode setting and start recording a 30-second clip of the bifurcation. Our goal here is to evaluate the presence of any microbubbles getting into the plaque, so we need at least 30 seconds on any plaque to see how contrast moves through it. Save that clip, then select Contrast Side-Side mode to get another clip of contrast and B mode at the same time. Note that this step is only available on Philips machines, and if you are on a GE machine, you will stop here. For Philips users, take another 30-second clip in the same view as before and save. During these, feel free to move around the bifurcation and internal and external carotid arteries if no plaque is initially apparent. Again, getting a longer video and more angles rather than less is helpful for our analysis. Finally, administer a second syringe of the contrast solution and repeat the process on the other side of the neck, remembering to relabel. Specific settings will be discussed with your site coordinator and included on the corresponding reference document. To summarize the contrast-enhanced images, you will take a 30-second clip of the bulb and internal carotid artery in long axis view in contrast mode, and then a 30-second clip in contrast side/side mode in the same position, and repeat both clips for the other side. Then you're all done. Thanks so much for being a part of research. We hope that this study will help us catch any moderate risk people who may have otherwise slipped through the cracks with a regular stress test. We appreciate your help with adding these novel images to the appointment. Happy scanning!